Greetings, my name is Brad Monk. I'm a gynecologic oncologist and I'm coming to you from Phoenix, Arizona. Here in Phoenix, I'm Division Director of Gynecologic Oncology at St. Joseph's Hospital and Medical Center, part of the Dignity Health Network. It's my honor to discuss with you today cervical cancer and the evolutions in the standard of care. As you may know, I chair the Energy Oncology Cervical Cancer Committee. I'm not here to represent that capacity, but I am going to share with you a lot of data that has been generated maybe by you through the legacy KGOG or Gynecologic Oncology group. I need to disclose to you that there's no intent here to be promotional. There's no intent here to persuade you, but simply to educate and teach people. But for the sake of disclosure, I want you to know that I have received honoraria from Genentech Roche, the same company, in some of the development of bevacizumab. So, but this is an independent talk. These are my thoughts, and I appreciate the opportunity to share them with you. I think we all know that cervical cancer is a global disease. It represents 9% of all new cancers and 8% of the total cancer deaths worldwide. And it's no secret that 85% of the deaths occur in the developing world. But it is still a burden here in the United States. And whether you're abroad or whether you're within the United States, it affects us. It's among us. Within the United States, there are about 12,000 cases and 4,000 deaths. To put it into perspective, within the state of Arizona, there are about 180 cases, and there'll be almost 80 deaths this year from cervical cancer. So this shows you the age-standardized cervical cancer rates. We only have it from 2008. They should be updated soon. You can see that North America here is at the bottom of this list, but as I mentioned to you, this is still an important disease, particularly if you treat women with gynecologic cancers. There's been a lot of discovery about the biology of cervical cancer. You're probably aware of Harold Surhausen, who won the Nobel Prize in 2008 based on his discoveries about the human papillomavirus, HPV, being in more than 90% of cervical cancers. You're familiar with the HeLa cells, which have been used in cancer biology in many settings, and certainly the Pap test. It says smear here, but we don't smear it anymore. We use liquid. But so the biology is understood, and by understanding the biology of these cancers, we can engage the biology and hopefully help patients. There are a lot of different types of HPV viruses. I think we realize that it's the high-risk types, 16 and 18 being the most common. I think we realize that we can test from the cervix for HPV, and it's a better screening test than the Pap test. And certainly the best strategy is HPV vaccination in young, sexually naive boys and girls. It's not just, though, the HPV biology that's interesting, it's the concept of hypoxia. The viral oncogenes in HPV interact with vascular endothelial growth factor and HIF-1 alpha to create a very unique environment where angiogenesis drives the cancer. Okay? This is a clearly understood pathway. It's something, again, that we can interact with, again, with the intent of helping patients. And so we're going to talk about anti-vascular endothelial growth factor therapies and how those therapies can help your patients. As a young man, looking under the colposcope, it became clear to me that when I would look at the progression of cervical intraepithelial neoplasia, from CIN1 to 2 and ultimately 3 and cancer, that I was seeing angiogenesis associated with tumor progression. The punctation and mosaicism associated with a high-grade lesion are the blood vessels growing from underneath the epithelium feeding the tumor, and the harbor of invasive cancer is atypical vessels. So again, this is a angiogenesis-driven cancer. We can see on the colposcope angiogenesis out of control, and if that's the case and if that's the biology, why don't we engage it and use it to help our patients? So I'm going to begin now in the early treatment paradigm. Radical hysterectomy is really the signature operation of gynecologic oncologists. We use it to treat tumors that are more than 3 millimeters deep and probably up to 4 centimeters in size. That would be a 1B2 lesion. We do this operation, which includes removal of the paracervical tissue. The ureters need to be dissected. Some people call this the Wertheim operation. The Austrian who described the largest series initially about this. The surgical anatomy as a trainee, we spend a lot of time learning how to dissect the ureters out through the tunnel. And now it's expanded. Now we can do smaller operations, some of which are fertility sparing, radical trachelectomy. We can also have radiation as an alternative in a patient that's unfit for surgery, intracavitary brachytherapy. And I think it's all about minimally invasive surgery, either laparoscopy or robotic surgery. And really, maybe we don't need to remove the paracervical tissue after all. And as you know, GOG 278 or Energy Protocol 278 is a prospective evaluation of less radical surgery for cancers that are deeper than 3 millimeters but less than 2 centimeters in size. So you and I together have worked within the Legacy GOG group to define when radiation or radiation and chemotherapy is indicated after radical hysterectomy. And radiation is used in this intermediate risk group, what I call 92-like criteria, the Sedlis criteria, landmark paper that showed that if the tumor is deeply invasive, large, or has vascular invasion, again, vascularity driving it, that radiation can improve outcomes. And in the higher risk patients where the lymph nodes are positive, the margins are positive, or there's parametrial or paracervical extension, chemotherapy and radiation should be used together. That's GOG 109. These are landmark papers. They've changed the standard of care, and I think that if you're not familiar with them, you should read them. And so we've learned in subset analysis that, again, a large, deeply invasive tumor should get radiation. This is the progression-free survival curves for GOG 92. I think it shows a clear benefit of adding radiation in this setting. The question is, should chemotherapy be used in that setting in the GOG 92-like Sedlis criteria? That's unknown. I invite you to enroll your patients on Energy Protocol 263. This is an international collaboration with the Korean Gynecologic Oncology Group investigating patients with this intermediate risk factors that we described, pelvic radiation, randomized to pelvic radiation and chemotherapy. These are the data from GOG 109, the higher risk group, the positive node, margin, or paracervical extension group, where chemotherapy and radiation are used together. And again, you can see a clear survival advantage. This was one of the 5 landmark studies from 1999 that led to the clinical alert that chemotherapy should be used with radiation in these high-risk cervical cancer patients. And this is the ongoing trial, again, another collaborative opportunity between Energy Oncology, the Legacy GOG group, and the RTOG, looking at more chemotherapy. You're going to hear as I go on that systemic therapy, chemotherapy, works in cervical cancer. So if it works when you give radiation and chemotherapy as initial treatment, maybe you should give additional cycles here, 4 cycles of carboplatin and paclitaxel. I invite you to enroll your patients on 0724. This trial is ongoing and is a high priority within the clinical trials network. So the global standard in more advanced lesions, again, based on this 1999 clinical alert, is chemotherapy and radiation, as I said. Surgery is probably not appropriate for these patients. These patients have not only intracavitary brachytherapy, but whole pelvic radiation. Frequently, it's a conformational radiation. The chemotherapy is a weekly cisplatin, 40 milligrams per square meter, capped at 70. And ideally it would be 6 doses. These are the sorts of external beam radiation ports that we use. These are right from our clinical trial protocol. I think you can see that there's a lot of area where local extension can be involved, and it's important that an adequate field is used. I told you that chemotherapy, after chemotherapy and radiation, is a valid strategy. I shared with you 0724. Well, this trial 0274, sorry for the confusion, is again additional cycles in that setting where surgery is not appropriate, where the primary treatment is chemotherapy and radiation. This is a randomized phase 3 trial, chemotherapy and radiation versus chemotherapy and radiation in 4 additional cycles. I invite you to participate in this 3rd ongoing randomized phase 3 trial that's running through the NCI Clinical Trials Network. So in summary, primary treatment, Surgery is a good option. CCRT, as the Asians say, concomitant chemotherapy and radiation, is used to treat locally advanced disease. I didn't go through the prognostic factors, but they're outlined here, that stage, grade, race, age, and certainly angiogenesis is prognostic. And we probably should use anti-VEGF therapies in the frontline setting, although that is not quite as advanced as in the recurrent setting. So let's switch gears. Let's talk about recurrent cervical cancer. It's terrible when it happens. We've done a number of trials. We did 6 of them that are outlined here, that platinum-based therapy are the most effective, that cisplatin might be more active than carboplatin. I'm going to refute that in a minute from a Japanese phase 3 trial. But we can increase response rate without improving survival 2 ways. Increasing the platinum dose from 50 milligrams per square meter to 100, or adding ifosfamide or even paclitaxel at that juncture. So based on all of that, really the world accepted after these 7 trials that cisplatin as a single agent should be used as a standard. Well, it was only until GOG 204 defined which platinum doublet should be used. This is an important, pivotal phase 3 trial. I had the pleasure of reporting it on behalf of the Gynecologic Oncology Group. This looked at 4 platinum doublets. The control arm was cisplatin paclitaxel. The 3 investigational arms, the vinorelbine, gemcitabine, and topotecan doublet. As you know, the topotecan came from GOG 179, the 7th trial that showed a survival advantage, but probably was a unique situation where the populations were changing. So again, the control arm was cisplatin paclitaxel. These are metastatic patients, stage 4B, about a quarter of them, but more commonly patients who had received frontline treatment and ultimately recurred. About 3/4 of these patients have had prior chemotherapy with their radiation. And you can see the survival curves published in the Journal of Clinical Oncology in 2009, where, if anything, the control arm outperformed the 3 experimental arms. In fact, this study was stopped for futility because the 3 investigational arms were never going to be better. And I think this helped create the global standard for the systemic treatment of recurrent cervical cancer. Cisplatin 50 milligrams per square meter, and then this was actually a 24-hour paclitaxel regimen given over 24 hours, although I'm not sure that's necessary. Certainly 175 of paclitaxel over 3 hours is acceptable and probably is not associated with the same degree of neurotoxicity as we thought it might be when this trial was designed, executed, and interpreted. The Japanese get that. The Japanese wanted to move a more convenient outpatient regimen to this setting of really palliation, no one's cured, of carboplatin and paclitaxel. So this is a non-inferiority trial done in Japan, carboplatin and paclitaxel versus the more inconvenient but previously established standard of cisplatin and paclitaxel. And the experimental arm, carboplatin paclitaxel, was paclitaxel, again, 175 over 3 hours and an AUC of 5, not 6. And you can see here, this has not been published yet, but will be any day, that this trial now presented 2 years ago at the American Society of Clinical Oncology enrolled 253 patients, again, maximum of 6 cycles, which again may or may not be correct because we generally treat patients until progression. And you can see that there was, the response rates were high. Remember, Asian patients probably have a higher response rate than non-Asian patients. That's a different discussion. But suffice it to say that it met its primary endpoint. The non-inferiority test is shown here, and you can see that the curves basically are the same. So the standard treatment at this point was either cisplatin paclitaxel or carboplatin paclitaxel. I can tell you that carboplatin paclitaxel is associated with more marrow toxicity, and in those patients, for example, that have extended field or aortic radiation, that carboplatin is probably not the best option because the bone marrow has been ablated more and there's a concern of thrombocytopenia. So there's clearly a role for cisplatin and paclitaxel and carboplatin paclitaxel together. So moving forward, we want targeted agents and new drugs. This is the only phase 2 that I'm going to show you. It's nanoalbuminated paclitaxel. I'm not sure whether the activity seen here, 28.6%, was related to the schedule weekly or whether it was the novel agent NAB paclitaxel. But this is an interesting concept, and I offer this to you if you're not aware of it, that Nab-paclitaxel, at least in a weekly schedule, is an interesting agent, and that is something that deserves further study. Back to our discussion about angiogenesis. I told you that the biology of HPV, HIF-1 alpha, VEGF are integrated. I showed you under the colposcope that the progression of cervical cancer is angiogenesis out of control. You know that you can engage VEGF with oral agents, pazopanib, cediranib. We're not going to go through those studies in great detail because I want to share with you the monoclonal antibody bevacizumab that binds and inactivates VEGF and what the ramifications are for safety, efficacy, and patient-reported outcomes. This all began with a phase 2 that was done within the KGOG. Remember, we do, within the 227 series, single-agent trials in patients that have failed standard treatment. These patients had failed, most of them in platinum, many of them in platinum doublet for the treatment of metastatic disease. In other words, this was second or third line for the treatment of metastatic disease. Single-agent, bevacizumab 15 milligrams per kilogram every 21 days, and we were surprised that it was an 11% response rate, not great, but the improvement in progression-free survival was dramatic based on our historical database. And this historical database included active agents. Said another way, in the phase 2 setting, single-agent bevacizumab was better than anything we had ever seen, okay? And well-tolerated, which, who knows, we didn't know that because these patients had been radiated. Again, published in the Journal of Clinical Oncology the same year as KGOG 204. So, with 204 being done, with 227C being reported, it's a no-brainer to add bevacizumab to chemotherapy in the phase 3 setting. That study, as you know, is called KGOG 240. Very similar eligibility criteria to KGOG 204, other than the fact that there were more restrictions on renal function. If these patients have hydronephrosis, that needs to be resolved, and the renal function needs to be optimized so that the patients can tolerate and get their systemic treatment. So KGOG 240 is a complicated study because it asks two questions. It was what we call a 2x2 factorial design. The first design was this non-platinum objective. Remember, I told you that these patients that were recurring had had platinum before. And maybe we shouldn't give them platinum again when they recur. So the idea was to take our two best non-platinum drugs, topotecan and paclitaxel, which is tolerable, they're both active, and to see if it was better than the traditional treatment that had been established in KGOG 204, cisplatin and paclitaxel. And so you see there are two arms because some of these patients have Bev, and that's the second objective, a 2x2 factorial design. So patients were randomized twice, once to the non-platinum objective and once to the bevacizumab objective. So this is the bevacizumab objective, adding to both chemotherapy regimens, cisplatin paclitaxel and topotecan paclitaxel, bevacizumab, with the primary endpoint being overall survival, trying to change the standard of care. So this is the non-platinum objective. I'm sorry, it was stopped by the Data Safety Monitoring Committee for futility. You can see that if anything, the topotecan paclitaxel backbone underperformed. Again, it was never going to be better than cisplatin paclitaxel. The hazard ratio was 1.20. So I think that although this is an interesting idea, most of us would not use this in treating recurrent cervical cancer unless there were very extenuating circumstances. Remember, topotecan and paclitaxel is inconvenient. The topotecan is given for 3 days. So again, I think this did not unseat or overcome the current chemotherapy standard of care backbone. Even in patients that had had prior radiation sensitizing cisplatin, there was not a benefit. So don't get distracted from that concept. It was a good idea, but it didn't hold. This is the bevacizumab objective. We were not surprised that it met its primary objective of prolonging overall survival in the setting of metastatic or recurrent cervical cancer. The response rates were dramatic, increasing it from 36% to 48%. This is the progression-free survival, which was a secondary endpoint, but if someone asks you, you can see here hazard ratio of 0.67. This is the overall survival when paclitaxel is used, increasing the survival by about 3 months, again a 50% response rate. Okay, very, very intriguing. And as you know, this has led to regulatory approval on August 14th through the FDA, making this available to patients who suffer from this terrible situation of advanced or metastatic cervical cancer. Here is a forest plot looking at various prognostic factors, and as you can see, when added to chemotherapy, bevacizumab improves overall survival across all the prognostic factors, even in an irradiated field, which we've never seen before, except in glandular cancers, adenocarcinomas. We've never seen a difference in adenocarcinomas compared to squamous cancers in our randomized phase 3 GOG studies. I don't know whether this is an aberrant finding or whether it's real. It certainly is a post hoc hypothesis-generating finding. Personally, I continue to use bevacizumab and chemotherapy in adenocarcinomas and adenosquamous cancers. In other words, I'm not persuaded by that observation. When one uses bevacizumab in recurrent cervical cancer, the first thing to consider is the sorts of patients that are ideally suited, and those would be patients who were the same sorts of patients that were enrolled on GOG 240, and you consider the toxicity profile. And the toxicity profile is real. GI fistulas, perforations, GU fistulas, okay, hypertension, neutropenia, even thromboembolism, okay? Suffice it to say that the vaginal fistula rate is 8%, the GI perforation rate is 2%, the GU perforation rate. So if you combine the perforations and the fistulas, 8 plus 2 obviously is 10. You need to tell your patient that, okay? That's the most important. The thromboembolism rate of 8% is not insignificant, okay? These are important factors in considering whether to use this agent in this setting and how to counsel your patients. I think, though, what's very important is how patients tell us they're feeling. Health-related quality of life, if you will, patient-reported outcomes. This was heavily integrated into this study. Patients were surveyed before cycle 1, before cycle 2, so after the acute side effects of the chemotherapy had worn off, and then during treatment as it rolled along. We used the FACT for cervical cancer trial outcome index, which looked at physical well-being, functional well-being, and looked at some specific questions that are important to cervical cancer survivors. And here you can see, although the lines look different, the difference was not statistically significant. It certainly was not clinically important, looking at 1.2. And so I think I can tell you that the survival advantage with bevacizumab is associated with toxicity I showed you, but it is not associated with a difference in patient-reported outcomes. Again, an important factor in considering whether or not to use this agent in this setting. So I graduated from medical school here in Arizona in 1988. I've been the chair of the GOG Cervical Cancer Committee since 2006. You can see the evolution of, in my lifetime, based on your work, and it's been a privilege to be a part of it. And I hope that you feel honored to be a part of it if you were. And if you weren't a part of it, I gave you examples of ongoing trials that you can be a part of, and I want you to be a part of it. But you can see the almost doubling of the survival over the years as we've done now 9 randomized phase 3 trials in recurrent cervical cancer. We've changed the treatment. We've improved outcome. These patients are very different than the sorts of patients where bevacizumab has other labeled indications. These are younger patients. These are patients that are frequently the matriarch of the home. These are women in their 40s. But this result of GOG 240 stands nicely when compared to the non-squamous cell and the first-line metastatic colorectal cancer indications. Okay? So I made this slide for you to put this into context of how bevacizumab is used in other cancers. So we didn't talk about pelvic exoneration. There are a few patients who have recurrent cancer localized in the cervix that can have a radical operation, removing the bladder and the rectum, and can be curative. But really, this is a palliative setting, and it's about platinum doublets. I say cisplatin here, but carboplatin, based on the Japanese trial, is also an acceptable doublet. and bevacizumab is probably now part of the standard of care. I told you that it was FDA approved. It's level 1 recommended by the NCCN, and I appreciate that. This is where I'm coming to you from, St. Joseph's Hospital and Medical Center in Phoenix, Arizona. I want to thank you for your commitment to the clinical trials process, but most importantly, to your patients and to the women that suffer from this disease. Thank you very much. So long for now.